everyone, my name is Irini. Today we're going to be discussing a bit together about warfarin and how we dose it. Alright, so what is warfarin? If you've worked in community or hospital, you might be familiar, with warfarin. A lot of your patients might be on warfarin, and you yourself might have been involved in the process of dosing warfarin. So essentially, warfarin is a vitamin K antagonist. It's an indirect anticoagulant, and it works on the liver by reducing its ability to produce coagulation factors 2, 7, 9, and 10. It also reduces the ability of the liver to produce its own endogenous anticoagulants, like proteins C and S. And when we say endogenous, that means it's produced by the body. Okay, so where do we use warfarin? So some common indications for warfarin includes things like stroke prevention in atrial fibrillation, or AFib for short. And what AFib is essentially just irregular heart rhythm. Also, it's used in the treatment of VTE, venous thromboembolism, long-term secondary prevention of VTE, and VTE prevention in patients who have mechanical heart valves. All right, so how do we dose warfarin, right? So there's something called maintenance dose, and there's something called starting dose. So the maintenance dose is the one that we maintain the patient on, right? Hence the name maintenance dose. And the maintenance dose varies. It can range anywhere from 1 milligram to greater than 20 milligram. And this is depending on a lot of patients, several factors that we're going to discuss later. But what dose do we start the patient on? Usually it's the 5 milligram dose. That's the usual starting dose for warfarin. However, it can be lower. It can be 1 to 2 milligram if the patient is frail, underweight, or of Asian descent. Now, important to note that warfarin takes quite a bit of time to start working, right? Its onset of action is anywhere between 24 to 72 hours, so 1 to 3 days, and with its full therapeutic effect that we generally see around 5 to 7 days. So until warfarin kicks in, until it starts working, the patient is initiated on low molecular weight heparin, LMWH, usually for 5 days, and until their INR is 2 for 2 days. Now, again, if you guys work in community or hospital, you might already know when I said low molecular weight heparin. What are some common examples? Think of some common examples of low molecular weight heparin. So things like enoxaparin or dalteparin, right? Those are common ones that we see in practice. Okay, so like I mentioned, there are a lot of factors that can affect the maintenance dose: age, weight, race, diet. Diet is also important, right? Because if patient eats a lot of, for example, green leafy vegetables, those are high in vitamin K, and we know warfarin is a vitamin K antagonist, right? So diet can definitely affect warfarin dosing. Let me just remove myself off the screen here for a second. Also, genetic variations in what we call the V-core enzyme. What is V-core? It's essentially vitamin K epoxide reductase, and this enzyme essentially converts like vitamin K from one form to another. Okay, so any variations in that enzyme also affects warfarin dosing. Also, if you have variations in the CYP2C enzyme, think to yourself, guys, what is CYP2C? Well, we know it's the enzyme that metabolizes warfarin. So if you have any changes in that can also affect the warfarin dose. Drug interactions, we're going to talk more about. Alcohol, we're going to talk more about. Other disease states can also affect the warfarin dosing, as well as levels of daily activity, so your exercise. All right, so monitoring. Now, before I go ahead and discuss monitoring, let's try to understand some of the key players in the process of clotting, okay? What are some key important factors that we have? So I'm going to discuss two things. We're going to discuss something called prothrombin, and we're going to discuss something called prothrombin time. So let me remove myself off the screen here for a second. So when I say prothrombin, and prothrombin time, PT for short. So PT is prothrombin time. Okay. So what is prothrombin, right? We know that prothrombin is actually a clotting factor. So it's one of the factors that are involved in the clotting process. It's also called clotting factor 2. So I'm going to write it here, clotting factor 2. Okay, so this is a protein. Essentially, it's a protein that is made in the liver, and like I said, it plays a role in the formation of blood clots. Now, prothrombin time, from the name, it's essentially a measurement of the time it takes for your blood to clot based on the activity of that protein, of that prothrombin protein. So if you have a longer PT, which is prothrombin time, that means it takes your body a longer time to clot. It takes your blood a longer time to clot, which essentially means that you are at higher risk of bleeds. Now, the opposite is also true. If the PT is shorter than usual, or the prothrombin time is lower than usual, that means your blood is clotting too easily. So you are at higher risk of clots. Okay? Now, clinicians use what we call PT tests, which is prothrombin time test, right? To sort of evaluate the ability of your blood to clot and how easily it clots, right? And this is usually measured in seconds. Now, the results of that test varies, right? Because there are different, lab methods. There are different, procedures that we can use to measure PT, the prothrombin time. So what clinicians have done is that they have come up with sort of more a normalized or a more standardized way of looking at the results, and that's what INR is called. It's International Normalized Ratio. So that's a more normalized way of looking at the clotting process. Okay. Now, like I said, so also with INR, if you have high INR, that means it takes your blood longer time to clot, which means you're at high risk of bleeding. So I can write here increased bleeding risk. And if you have lower than usual INR, that means that your blood is clotting too easily, so you are at higher clotting risk. Your risk of having blood clots is higher. Okay, so on warfarin, once a patient is started on warfarin, and actually also during the maintenance phase, routine monitoring is required. Okay, our target INR for most patients is usually 2 to 3. Okay, however, if they have a mechanical mitral valve, their target is a little higher, 2.5 to 3.5. Okay, now like I mentioned, right, it takes 1 to 3 days for the warfarin to start working, with a full therapeutic effect seen in about 5 to 7 days. So that's why it normally takes 3 to 7 days, depending on the specific patient factors. Now, because it takes at least 2 days for us to see an effect, that's why monitoring should be done in no earlier than 2 to 3 days after you initiate, or if after you do any sort of dose adjustments. Okay. Once a patient is stable, that frequency is usually reduced to once a month. So most of our warfarin patients are monitored just once a month. If a patient is very stable, some physicians will choose to monitor every 3 months, so every 12 weeks. But usually what we see more common in practice is the monitoring once a month, once a patient is stabilized. All right, so warfarin is important, right? And it has a lot of potential interactions. That's why I like this slide. Why? Because this is where we really, this is where we come in, right? We have to ask a full, thorough medical history and social history, because a lot of things might impact warfarin and how it works and whether or not we need to do those adjustments. So warfarin, we know, is an anticoagulant, right? It's also essentially a blood thinner. So if you combine it with other blood thinners like antiplatelets, that will increase the risk of bleeding, right? Actually, the risk of bleeding is almost doubled when you combine an antiplatelet like aspirin or clopidogrel with warfarin. NSAIDs, non-steroidal anti-inflammatory drugs, right, also can increase the risk of GI bleeds and ulcers. So we usually like to avoid putting a patient on an NSAID if they are on warfarin, but if we really need to put them on an NSAID, then we like to use our PPI, proton pump inhibitor, to sort of reduce that risk of GI bleeds. Antibiotics is also a common interaction with warfarin. Many antibiotics will actually increase INR. Why? Because they increase the warfarin effect, right? And if you have more warfarin, that means high INR, higher bleeding risk. However, there is one exception. One of the few exceptions is rifampin. I just thought it's interesting, so I thought I'd mention it to you guys. Rifampin actually does the opposite. It increases INR. Okay, so by increasing INR, why does it increase INR? Because it essentially reduces the warfarin effect, or reduces the warfarin concentration, reduces INR. What does it do to the clotting? Increases clotting risk. Okay, acute infection, right? Think when you're acutely ill, you might be nauseous, you might be vomiting a lot. Also, your diet might be changing, so the vitamin K intake might be changing. So during the course of an acute infection, the warfarin, you might need to monitor more frequently to see whether or not you need to adjust the warfarin dose. Alcohol is pretty interesting. I'm going to write something here on the screen, so I'm going to take myself off the screen shortly. But it really depends. Essentially, with alcohol, it depends on whether or not you are acutely drinking. So just that one weekend you went wild, you drank a lot, or you're more of like a chronic side of things. So you've been drinking chronically. So here is what. Now, the evidence that we have is not very clear, but there seems to be a consensus on the following. Maybe I can write it here. So we'll start off here. So usually with acute drinking, you guys, if you want, you can add these to your notes as well. With acute drinking, there is increase in the alcohol concentration, right? That leads to decrease in warfarin metabolism. And how is warfarin metabolized? It's through the CYP pathway, like we mentioned, metabolism. And when you have decrease in warfarin, think about what that does to the INR. Give you guys a couple seconds here. So if you guys thought increase INR, you're absolutely right, because you have less warfarin. And this, with the increase in INR, you have, like we said, increase in bleeding risk. So again, this is what happens with acute drinking. Okay, but what if someone is chronically drinking? They've been drinking for a long time. So I can write chronic drinking or chronic consumption of alcohol. Consumption. It actually does the opposite. It increases the warfarin metabolism. Okay, and think about what that does to the warfarin. So if you have increased warfarin, that means metabolism, that means your warfarin concentration is decreasing. And what does that do to your INR? Exactly, decreases INR, because now you have less warfarin. And with decreased INR, what do you have? You have increased clotting risk. Okay, so really the effects of alcohol tends to be the opposite on based on how much and for how long you've been drinking. Okay, so acute drinking versus chronic drinking or chronic consumption. Okay, so I hope you guys wrote that down. So last thing we're going to talk about is some supplements, natural health products that are out there. And that's why, again, I can't stress this enough. Very important to ask about over-the-counter OTC products, right? Over-the-counter non-prescription products that the patient might be taking. So the first thing we have is St. John's wort. Can you guys think of, some uses for St. John's wort? Or if you practice in community, what are usually your patients using St. John's wort for? St. John's wort is sometimes used in depression, right? It's, like I said, it's a natural health product. And what it does, it actually decreases the effect of warfarin. And again, think about that, what that does to your INR. So you have decreased warfarin, you have decreased INR, and like I said, increased clotting factor. Okay? Clotting effect. Ginkgo biloba actually increases your INR, so that's why it increases bleeding risk. And ginkgo biloba, if you guys haven't heard of it before, or ginkgo biloba, some people say it differently. It's essentially it has like some anti-inflammatory and antioxidant properties to it. Okay, so lots of drug interactions that we need to monitor and look at, especially if you have a new patient with a new prescription for warfarin. Very important to gather a full social and medical history. Okay, so when we talk about warfarin dosing, it's also important for us to talk about warfarin reversal, right? What if there has been an accidental warfarin dosing that you want to reverse? What do we do in that case? Well, we have two options. The first one, the more common one, is we know warfarin is a vitamin K antagonist. So how do you reverse that? You give vitamin K, right? So the first option we have is vitamin K. Usually the dose is 25 to 10 milligram. You measure the INR after 12 to 48 hours after you give the vitamin K, and then you also administer if you need any sort of subsequent doses. After you administer it orally, you expect the reversal to occur in 24 to 48 hours. Okay? Now, in an emergency situation, you don't want to wait for the oral effect to kick in, right? You need something faster because you need to reverse right away, right? So IV in that case obviously works a lot quicker. So in case if you need an emergent or an urgent reversal, you give intravenous vitamin K or octaplex or periplex, which are 4-factor prothrombin complex. So they are also involved in that clotting process, right? So notice here, you measure it a lot more quicker or earlier than when you would with the oral administration, because it's IV, it works quicker. And again, you can also administer any subsequent doses as needed. Okay, so now let's say scenario, you have your patients, on warfarin for a long time, they've been stable on it, and then all of a sudden, you get an out-of-range INR, right? The INR is no longer within the normal range, which is what did we say the normal INR range was? 2 to 3? Yes. Okay. So what if they have this, what, an out of range INR? Well, we need to consider what else is happening, right? Something might have changed. So you ask the patient some questions. What do you ask? Have you missed any doses in the past week, right? Is there any non-compliance issues that we're worried about? If there is, you want to try to improve their adherence or improve their compliance, right? So you offer to arrange their medications in blister packs. That's very common in community. Phone reminders, dosing calendars, right? Anything that will help improve their adherence. Have they started or stopped any medications or supplements recently, right? We spoke about antibiotics, right? And how they can affect the warfarin and INR. Azole antifungals are also azole antifungals can actually increase the warfarin effect. And what does that do to INR? If you have increased warfarin, increased INR, increased bleeding risk. Okay, levothyroxine can also change the INR. Also ask about their diet, right? Has their diet recently changed, right? Vitamin K rich foods, like we said, your green leafy vegetables, your soy, your avocado. Now, we're not saying that patients should not be taking or should not be consuming vitamin K rich foods, right? Absolutely not. We actually, on the opposite, we want them to be more healthy. You want to advise them on eating, lots of green vegetables and fruits. But the important thing here is consistent diet, right? I can even write it here. Consistency of the diet. So let's say they've been, on a certain diet for a long period of time while they're on warfarin, and suddenly that diet changes and they start taking a lot more, vitamin K rich foods. That's obviously going to affect their warfarin and their INR. Okay. We spoke about alcohol and how that affects the INR. And again, this is the acute infection that we spoke about. Infection. Okay. So now that we've asked sort of all the questions and we determined that the INR does need adjustment, our next question will be, okay, so are we changing only a single warfarin dose, or we actually want to change the whole maintenance dose, right? So to change a single dose would be the option if the INR is only slightly out of range, right? So if it's 0.5 above or below the target, and there is a transient cause that you have identified, okay? In that case, how do you do the change? You make, like I said, a one-time dose change, so either increase or hold by half a dose to one dose, and you can then resume the current dose. Or some clinicians will not, do sort of any dose, they will just continue on the current dose. You have to repeat the INR in 1 to 2 weeks. So that's if you want to do a single dose change. Now, if you want to change the maintenance dose, which would be the option 1, if there has been a 2 or more out of range INR. In that case, it would make more sense to change the maintenance dose if you have 2 or more out of range INR. Now, how do we go about changing the maintenance dose? This is what we're going to be discussing here. Okay, so this is changing the maintenance dose. And remember, our target is ultimately 2 to 3 for most patients. Okay, now how do we change the maintenance dose, or how much do we change it by? It depends on what the INR is, right? If the patient's INR is now less than 2, it makes sense that you want to increase the dose, right? Because less than 2 means more clotting risk, so increase the INR, okay? So you increase by what? You increase by 10 to 15%, and you repeat your INR within 1 week. Now, what if the INR is higher than target? It's 3.1 to 3.5. So now if it's higher than target, you really want to decrease, okay? Because higher than target, high bleeding risk, decrease INR. That's what you want, okay? So if the INR is 3.1 to 3.5, you want to decrease by 0 to 10%. Repeat your INR within 2 weeks, okay? The INR is higher, so 3.6 to 4. Usually that's when you're going to start to hold some doses, okay? So hold as in do not give that dose to the patient, okay? So you can hold one dose and decrease by 10 to 15%. Decrease what? Decrease your maintenance dose, okay? Repeat INR within 1 week. If the INR is even higher, 3.1 to 8.9, now we're getting in a bit in the danger zone here, because that very high INR, very high bleeding risk, okay? You can choose to hold up to 2 doses and again decrease your maintenance dose by 10 to 15%. Repeat INR in 2 days. Now we're getting more serious, we're getting again more in the danger zone, so that's why you want to start doing your INR more frequently, okay? Or earlier, I would say. So here you repeat the INR in 2 days. Now, INR is super high, more than 9, very dangerous. You're absolutely going to hold 2 doses and decrease by 15 to 20%. You're going to repeat your INR in the next day. Usually that's what clinicians do because they really worry about, I would say, you know, this is when you really, again, get in the danger zone. So that's when you want to start to hold more doses, repeat your INR more quicker or more frequently. Okay, so an important thing to note here, guys, is when we say increase by, we're not referring to the percentage of the daily dose. We're referring to the percentage of the weekly maintenance dose. So essentially changing the percentage of the weekly maintenance dose. That's the percentage that we're changing. Okay, so next we're going to talk about perioperative warfarin management. So when someone is, you know, let's say you have a patient, they've been stable on warfarin, you know, for a long time, everything is going well. Now they need to go for a surgery or an operation. So when they are on warfarin and they are scheduled for a surgery or operation, you will need to stop warfarin sometime before surgery to reduce the bleeding risk, right? We don't want the patient to bleed on the table, and we know sort of warfarin already puts them at a higher risk of bleeds, and when they're having like an operation or surgery, that also puts them at a bleeding risk. So you want to stop warfarin before surgery to reduce that bleeding risk. Now, this goes for most, I would say, majority of the operations or surgeries, but there could be minor operations that the clinicians or the doctors might choose not to stop warfarin. So things are like cataract surgeries, for example, right? And eye surgery. So the clinicians might not stop warfarin. Very minor dental procedures like a root canal or something. Again, some doctors might choose not to stop warfarin. But when we're talking really about here is the major sort of big surgeries. So things like orthopedic surgery, neurosurgery, or cardiac surgery. So big things that you really need to consider stopping warfarin before surgery. Again, to reduce that bleeding risk. Now, when we stop warfarin, you still need to use something, right, on the days leading up to the surgery where you have stopped warfarin. Because think about the original reason you started your patient on warfarin, is that you want to reduce the risk of clotting. That's why essentially the patient was started on warfarin. So when you stop warfarin, you put your patient at a higher risk of thromboembolism, right, of having clotting. So you sort of want to maintain sort of, okay, I need to stop warfarin because to reduce the bleeding risk before surgery, but I also want to make sure to put them on something that will reduce their thromboembolic risk, right? So this is what we call bridging. That's when you stop warfarin and you use something else on the days leading up to the surgery to reduce the risk of thromboembolism, okay? So when is bridging required? If the patient is at high thromboembolic risk, you do bridging. So high thromboembolism is when they have a mechanical prosthetic mitral valve in place, for example, or they have a mechanical aortic valve that is older, so older generation. Their CHAD score is 5 or 6. If they've had a recent stroke, transient ischemic attack, TIA, DVT, deep venous thromboembolism, PE is pulmonary embolism, so any recent sort of cardiac events within the past 3 months, or if they had a VTE during interruption of warfarin therapy. That's when we say they have high thromboembolic risk, and that's when we recommend bridging, okay? Now, just a quick refresher. When we say CHADS, think about what that acronym means, right? So I can write it here just to refresh your memory here. So congestive heart failure, so that's the C. You have H is hypertension. Oh, sorry, hypertension. What do you have age? A is age greater than or equal to 75. Maybe I can continue here. D is diabetes. Okay, and then S is stroke / TIA, and that gets 2 points. That's why we have 2 here, okay? So CHAD score of 5 or 6, automatically high thromboembolism risk, okay? Now, what if they have intermediate thromboembolic risk? Bridging is optional in that case, and that could include, so how can we determine if they're intermediate, not really high? So if their CHAD score is 3 or 4, if they have a newer mechanical, aortic valve, or their VTE is within 3 to 12 months. So recent, but not super recent, okay? If bridging is required, you stop warfarin 5 days pre-op, so prior to surgery. You get your INR on post-op day -1. So when I say POD is post-op day, POD 0 is the day of surgery, okay? And then POD -1 is the day before surgery. So you get your INR, so you stop warfarin 5 days pre-op, that's very important. You get your INR a day before surgery, so post-op day -1, and then you use your low molecular weight heparin, so like enoxaparin, dalteparin that we spoke about. You start it 3 days before surgery, Okay, that's when bridging is required. That's how you do it. Okay, now if bridging is not required, easy. Okay, so just stop warfarin 5 days pre-op, and again obtain your INR on post-op day -1, so the day before surgery, and you don't have to do bridging if bridging is not required. Now, an important thing to note here, guys, is that the guidelines are not, they tend to get a little confusing because they use CHADS 65 to determine if a patient is appropriate for an oral anticoagulant. So determine whether or not, for example, to start a patient on warfarin, for example, the guidelines use CHADS 65. 65, you guys might know, this is just the age. So age 65 is one of the determining factors of whether or not to start a patient on an oral anticoagulant. But in order to determine whether or not to bridge, the guidelines are still using the CHADS 2 score. Okay, so that's when the guidelines are not super clear, and really if you think about it, it's just a 1-point difference, and in practice it really depends on like overall patient factors, and that's up to the clinician to decide. Okay, just wanted to let you know, guys, like what factors or what CHADS the guidelines are using, in case you look at the guidelines and it's a little confusing. So bridging, just know that they use the CHADS 2 score, but CHADS 65 is what they use in the guidelines to determine whether or not to start a patient on an oral anticoagulant. Okay, just wanted to let you guys know this. Okay, so now let's try to sort of consolidate all the information together, and we're going to do some practice questions. Okay, so Mrs. TB is an 82-year-old female who has been on warfarin for 20 years. She has been suffering from joint pain a lot recently and has been scheduled for a total knee replacement next month. TB has a past medical history of previous stroke, osteoarthritis, type 2 diabetes, hypertension, and AFib. She takes acetaminophen 1000 mg BID, metformin 1000 mg BID, warfarin 4 mg daily, and amlodipine 5 mg PO at bedtime. She has no known drug allergies. Her blood pressure is 125/80. Her CHADS 2 score is 5. VASP is her pain scale is 7 out of 10, and her INR is 2.6. Which of the following would be an appropriate recommendation for Mrs. TB pre-op? Just going to give you guys a second to think about that. Okay, so the correct answer here will be C. If you guys said that, that's right. Why? Because her CHADS score is 5. That puts her at high thromboembolic risk. So bridging is recommended. And how do we bridge? You stop your warfarin 5 days pre-op. You give enoxaparin, which is your low molecular weight heparin, 3 days pre-op, and then you stop 1 day before surgery. So until 24 hours pre-op. So C is the correct answer for this question. All right, so it has been 2 months since Mrs. TB's surgery. She's very pleased, good, and seems to be in much less pain than prior to her operation. She visits her family physician for a routine follow-up, and her INR comes back as 1.7. Which of the following could be a reason for that? Okay, so her INR is usually around 2.6, but at during her last doctor visit, it was 1.7, so it decreased. Which of the following factors could be contributing to that? All right. So, if you guys thought B, you are right. B is the right answer because essentially everything else will increase her INR. But here we see that her INR has decreased. And we spoke about St. John's wort. It can decrease the INR, okay? So she might have started recently taking St. John's wort to help with her low mood. All right, last but not least, Mrs. TB has had 2 out-of-range INRs over the past few weeks. One came back as 1.7 and the second is 1.6. Which of the following is appropriate in her case? How do we do the warfarin dosing or the warfarin adjustment? Give you guys a couple seconds to think about that. Okay, so if you guys said C, you are right. And here's how you can do process of elimination for this one. So right off the bat, I want to eliminate B and D. Why do you guys think I should eliminate B and D? Yes, because here it says increased total daily dose. Nope. Increased total daily dose. Nope. We said that increase is of the weekly maintenance dose. So it's not the daily dose, it's the weekly maintenance dose. Okay, so we are left with A and C. So A says increase total weekly dose by 10 and repeat INR in 3 weeks. Increase total total weekly dose by 15 and repeat INR in 1 week. If you guys go back here to our chart, we see if it's less than 2, you repeat INR within 1 week. Okay, so that's why answer C is the correct one, because that you want to repeat it in 1 week. You don't want it repeated in 3 weeks. You should repeat it in 1 week. All right, so that concludes our presentation. Thank you very much for listening.